The next speaker is Julian Prescod. He will give us a literature review investigating the relationship between socioeconomic status and the allocation of healthcare services by the public primary healthcare system. Julian he works at the NIB of Trinidad and Tobago, the National Insurance Board. He currently is the Research and Development Officer. He has experience in planning in the education sector. He was the recipient of the CARICOM Scholarship in 2003. As we said earlier, he also pursued his studies in health economics under Professor Carl Theodore, and his research interests are in equity and the delivery of primary healthcare services. I hand it over now to Julian.
Good afternoon, everybody. What I'm about to do is almost like a checklist on my experience in terms of when we begin doing our research in the issue of social economic status and the allocation of healthcare services, and particularly so in St. Vincent and Grenadines. I'm not going to present any findings at this point, but mostly the experience of how we got to where we wanted to be. In the introduction, I highlighted three key things that drew me to this discussion and the relationship between these two factors. The first one was the NASA Declaration 2001, the wealth of the region is the health of the region. The second thing was what was more grappling though, when in reviewing what we call the country poverty assessment of St. Vincent and Grenadines in 2008, the concern was the scarcity of healthcare services in communities in St. Vincent and Grenadines. And then I asked myself, okay, in 2001, the wealth of the region is the health of the region. But in 2008, you're hearing the conversation that the scarcity in healthcare resources, you can't have access to these resources. And then the third component was poor health reduces the ability to acquire the necessary capabilities to achieve one's best. So I put this into context and I asked myself, if the situation is that we have an equitable allocation of healthcare resources, then the challenge of the first statement, well, you have a challenge in terms of the first statement. So I attempted in my research to ask myself the question, is there a case in St. Vincent and Grenadines in terms of the issue of scarcity of healthcare resources, and is there any relationship in terms of who gets what? The outline of the presentation may look a bit lengthy, but the first part of it really is about what the discussion or the lecture is talking about, the theoretical discussions it was, and I try my best to summarize, we'll give the time we have to present and so on, in a way that you can follow and appreciate what follows in terms of the actual experience on the ground in St. Vincent and Grenadines. So we have a investigation research approach, a representation of findings, equity in healthcare, the issue of healthcare and the social determinants of health, the guiding philosophy, some discussion on the role of the health as the state government in this case as a provider of healthcare. And we talk about financing and financing and the relationship between access and utilization. And what we found out in the process is that it was taking us down the road to something about measurement because there wasn't sufficient evidence available in terms to tell us, okay, is there an issue in terms of the relationship between social economic status and allocation of healthcare resources? And of course, conclusion. So to conduct the lecture review, in the relationship between social economic status and so on, allocation of healthcare services. And I will tell you the findings from this review was used to guide the research, and at the time I was studying, completing MPhil PhD candidate at the University of West Indies, right here at St. Augustine. And we were talking about, subsequent to that, the findings in this review, our intention was to apply, of course, relevant theoretical framework, which will help us and guide us in terms of the methodology to say, okay, does inequity in any case exist? Of course, combination with MPhil PhD thesis. Now the research approach, if I can summarize, the first part, which was very much generalized because I know the literature is out there and I'm one company who I'm quite certain will take me to task if I even hesitate to make a mistake somewhere in that presentation. So to be a cautious batsman, I stick to what I know a little bit more of, which is the experience in St. Vincent and Grenadines. So the first part was the bibliography, things that guide me along the way, and so on. But the latter part, or the middle part, down in national documents, I went through a set of documents. It's almost like I was a checklist, which is asking myself this question. Is there a genuine situation in St. Vincent and Grenadines in terms of getting the persons who need the resources to get these resources? And I must mention to you at the latter part, the last part of the research approach, I tried to do my best to put in the time frame of the expiration of the, what we call it, National Health Strategic Plan. It was 2007, 2012. But the joke was on me in the sense that in 2010, I think it was, the statistics department had a little fire. So we had some challenges in terms of getting additional data. So I had to cut off the data set to 2010. What I have is just a set of concepts, discussions in terms of what came from literature. And how could we best use this information in terms of addressing the issue of measurement or measuring, at least trying to develop some kind of method or methodology to measure experience of inequity in St. Vincent and Grenadines. In terms of socio-economic status, our big concern, of course, was we wanted to establish income levels, and almost rigidly, we went immediately to sort of Marxist approaches and decided something we're going to use income levels, and it was also identified as one of the best indicators in terms of measuring equity, And then we proceed on to poverty gap. Again, based on data, availability of data, we had to do some tasks and so on. We eventually stopped with poverty gap, which is a measure of difference between the poverty line and the minimal provision of services to bring a household up to meet the poverty line, St. Vincent and Grenadines, and it was using the country poverty assessment. Now, if I could hesitate to stop a little bit, there was a deliberate attempt to use local resources to come to reach at some means of being able to monitor and evaluate this relationship in St. Vincent and Grenadines. And of course, sometimes you have to use what you have. So basically, that is what I was trying to get at. How best could local resources be applied, even if it might be in a rudimentary way, to monitor these things before, as it were, bringing the big guns, as some of us normally like to say. Now, one consult, well, based on St. Vincent and Grenadines Poverty Assessment Report, 2007-2008, CDB, the dollar value they had here, and if you convert to Trinidad and Tobago dollars, might be $11,000, $12,000. The first thing came to my mind was the first thing, you're a doctor, you have the diagnostic, and you have the, the symptoms and all these things. This low income level, we ask ourselves, is that setting us up in a way to more or less, I want to say to a foregone conclusion that maybe there's a concern for equity in allocation and resources, because it's normally, inequity to a large extent is normally tied to poverty levels and non-poor accessing more and less than, and poor accessing less and all these issues. So just develop a sort of checklist as you're going along. And then we saw this. We have all the health districts, 9 health districts. We have the size of the population, and in the middle we have the poverty gap. And if you notice, within the middle, these values, if you notice Northern Grenadines and Southern Grenadines, this is what we call the tourism belt, which I guess might be, you can compare the oil belt in Trinidad and Tobago. This is where, in inverted commas, most of the wealth is generated from tourism, with the exception of, say, Georgetown, for example, Chateaubriand, all these places. These places are more agricultural area, and in these places, of course, banana production and in St. Vincent and Grenadines, if I can use colloquial language, we're big in banana production, but as I go into the presentation, you will recognize that there were several problems we encountered, which caused us to, in inverted commas, lose some of the benefits of this sort of exportation of bananas to Europe. Now, in a broader context, discussion started to say, okay, let us look at the social determinants of health and put into context the experience of provision of healthcare services. Now, while we recognize that healthcare is a very important, provision of healthcare services is a very important contributor to the maintenance of proper health status or health status. So from the broader context, therefore, this is where we started. And I said, okay, we look at the community level. And the issue at the community level is that the literature told us, okay, communities could be homogeneous. That is, the people in a community might have similar features, but then be heterogeneous in that different communities have different characteristics. So this is the broad sense that we started. And then we delve in further, we try to narrow research and so on. And I want to pay special attention to the fifth bullet down, where we talk about the difference between incidence and severity. And in particular, severity in terms of resulting from diseases, and in terms of severity in terms of, when we talk about severity, we're speaking specifically in the application of how do you treat the list of health status. And what we found out in literature was that the severity of a disease is more treated by the healthcare delivery system, where the incidence might be of non-inverted comma healthcare issues. So then we narrow it down to, okay, severity of the disease, deliver healthcare delivery system, but we also found out too that in terms of being able to treat with the issue of severity of disease, the best mechanism and the best approach was the use of primary healthcare services. So we sort of narrowed and keep narrowing and so on. So then having reached a point where it's okay, it's developed primary healthcare services, the next thing we went on to do is look at what constitutes the public health delivery system in St. Vincent and Grenadines. And thank you. You will see a slew of things, slew of services, 39 clinics, 5 district hospitals, and so on, 9 health districts. The services offered by primary health care facilities and so on. But there's one distinguishing feature out St. Vincent and Grenadines. It's a multi-island state, where you have 32 islands with the mainland St. Vincent and Grenadines. So even by geography itself, you had some challenges, and I will show you a little bit earlier on. We look at the health districts. The Grenadines themselves were set of islands to the southern end of St. Vincent and Grenadines, and which incidentally, few are very habitable. And there's also challenges in terms of ensuring these facilities remain operational. At least operational through the week for a couple of days. Mostly we're opening twice a week and so on. So access is a challenge to that extent. We know in St. Vincent and Grenadines, in terms of, when we look at the strategic health plan for Ministry of Health, yes, there's support of equity. Yes, there's consultation. Yes, the whole issue of actual welfareism and the philosophy about prioritizing certain needs and all these things. Yes, so they have all these things nice and cuddly in the strategic plan and so on. It means well-intended and so on. But then when we want to narrow again, the focus again recognize that there is some issue in terms of, okay, who gets what? And again, the literature reminds us that, you want to make sure in times of challenges, that's a time of challenging, but you cannot provide for everybody. And therefore, the issue of actual welfareism, you have to establish need. In establishing need, you also be cognizant of the fact that you cannot provide all these services, but then you should at least have some sort of minimum package so that those persons particularly, access to everybody, of course, but you want to have a minimum package because a question of affordability arises. When we look at the annual health expenditure for the health district, what we saw was a movement up and down, a sort of fluctuating relationship diagram. And while I remember hearing when you presented this morning, talk about mixed financing for healthcare and so on, for provision of health services and so on. But what we do in St. Vincent and Grenadines, and I know Professor Taylor was a part of a team of persons who were involved in it, there was the issue of national health insurance, and I don't know if I could take an advice, that there was challenges in terms of political will and so on. I think I'll stop right there at that part. But what we recognize that from some work done by a colleague of mine, Adams, his research showed that Vincentians in particular were ready in terms of some form of national health insurance. But added to that, you had all the other issues, user fees, out-of-pocket expenditure, and all these things. Now, again, user fees this morning was mentioned this morning in the presentation, and the issue with user fees, which was still being offered in St. Vincent and Grenadines, actually, at the time of the research, we know the challenge, if you can't pay, you might not want to access, and some other issue of transaction, you have to move from one place to another, and all these other issues in terms of how do I access healthcare resources. So what we do now, therefore, and against the methodology issues, is that we wanted to ensure now that, okay, so we see any signs that there might be a possibility of concern for inequity in the allocation of healthcare resources in St. Vincent and Grenadines. What this slide does, therefore, was put into context how should we therefore go measuring it. So therefore, the monetization issue is about identifying the proportionate budget, particularly allocation to primary health care. What's the allocation to primary health care? Who is accessing these care, and so on. I have 1 minute. So I'll just straight. I think I want to also spend a little more time on the constraints, because the constraints is what limited or what limits the space of what our researchers train us. So we know for a fact that the conditions were there. There's the issue of poverty levels varying across the place. We saw to a large extent that even though the issue of equity arises, there was no real evidence of measurement of equity at the time, equity allocation of sources. And there's also the concern of mixed financing in terms of what do you do? How do you therefore provide to ensure that equity does not exist? But being that those questions you were asking, well, I indicate some of the limitations. At the bottom where the fire actually got some of the statistics. But just to conclude is that what we found out, the issue was, again, the relationship was a question of equity. But what I can say, although I'm not having presented here, we recognize that it wasn't so much a question of differences in allocation between as a result of socioeconomic status, that is to say the poor getting less and the rich getting more. But what we found out mostly was simply because since it's been a multi-island state, the size of operation, the facilities, places some serious constraint on what the public health system could have offered. Are we finished? Oh, well, thank you very much. Thank you very much.